اگه اجازه بدیم برنامه رو شروع می‌کنیم.
Can I, one quick, Dr. Dahi, you're not in the presentation mode.
I'm not in the presentation mode.
No, if you kind of, you can swap it at the up at the top.
Yeah, that's what I was looking for. And wait, where at the top? Do you see my screen?
No. Do you see that?
Okay, hello everyone. It's now 7 p.m. in Iran, and it's about the time we should start the program. And at the beginning, I would like to give you a brief introduction of myself. I'm Dr. Marjan Yaghmai, Associate Professor of Medical Genetics at Tehran University of Medical Sciences and Head of the Leading House for Iran North America Academic Partnership, which has set up this series of educational programs. We are glad to hold the 7 parts of webinar series entitled Conditioning Regimens and Donor Sources for Stem Cell Transplantation. First of all, I would like to express my heartiest gratitude and welcome to you on behalf of myself, Dr. Kurdi, the TUMS Vice Chancellor for Global Strategies and International Affairs, and Dr. Nekufar, the TUMS Director of International Relations, and with a special thanks to the Appraise to Raise team who helped me to organize this series. It is a great honor for all of us to virtually have you all here. And before we start, I would like to thank Dr. Shadman, Associate Professor of Medical Oncology at the University of Washington, who kindly facilitated these connections between TUMS and great hematologists in the US. And actually, I'm going to ask him to introduce our valued guest speaker, Dr. Parastoo Dahi. And following that introduction, Dr. Marcy, our moderator, will start the program. I hope you will find this webinar informative and helpful. Dr. Shadman, please.
Hi, everyone. Today it's my pleasure to introduce Dr. Parastoo Bahrami Dahi, who is an assistant professor of medicine the bone marrow transplant service at the Memorial Sloan Kettering Cancer Center in New York. She's also a faculty at the Weill Cornell College in New York. She's a graduate from Tehran Azad University in Iran, and she finished her internal medicine residency and hematology oncology fellowship at the State University of New York. She then finished an advanced fellowship for bone marrow transplant at the Memorial Sloan Kettering, and then she joined the faculty there at the Sloan Kettering Center in 2013. She's board certified in internal medicine, hematology, and medical oncology, and she's a clinician and investigator with a focus on bone marrow transplant and cellular therapy, where her focus of research is access to these modalities and also improving the clinical outcomes. She has authored a number of articles, and she's a very active member of American Society of Hematology and American Society of Transplant and Cellular Therapy, and I've had a pleasure of knowing her for years now through these professional meetings, and thank you very much, Dr. Dahi, for joining us today. With that, I turn the microphone to Dr. Marcy for continuation of this program.
Hi, everyone. I'm really honored to be your host tonight. Very briefly, I just wanted to introduce our institute. As a referral center from all over Iran, more than 300 patients undergo HSCT every year in our institute. As TBI is not really accessible for us, all of our patients undergo radiation-free conditioning regimens, mostly myeloablative regimens with busulfan and cyclophosphamide plus cyclosporine as GVHD prophylaxis. In our haploidentical HSCTs, we use dual in vivo T-cell depletion by ATG and POSI. And the most common graft source that we are using is peripheral blood. So overall, I can say that our graft failure rate is really low, and the rate of GVHD and relapse in our patients, I can say it seems to be comparable to what it is reported in the literature by others. Thank you, and now we are all ears to hear you, Professor Dahi.
Thank you so much. با سلام و درود خدمت همه همیهنان، همکاران محترم و با تشکر از گردانندگان این وبینار. خیلی خوشحالم که امروز در خدمت همگی هستم. Thank you, Dr. Shadman, for the kind introduction. And I would like to thank the meeting organizers, Dr. Yaghmai and her team, as well as the meeting facilitator, Dr. Q. Marcy, for inviting me to this webinar. I'm really excited to be here with you today. So I have no relevant financial conflict of interest to report. I'm starting with a picture of New York. So this is New York City, this is Manhattan, and Memorial Sloan Kettering is this building. This is the main campus. We have several campuses throughout the city. This is the main hospital where the transplant activities are mainly performed, and across the street from us is Weill Cornell Medical College. It's right here. And then we have Rockefeller Research University right across us as well. And this is a close screenshot from the hospital, Memorial Sloan Kettering. And I have been here since 2011 when I joined as a fellow in BMT. So the outline of my talk today are basically three things. One, to go through principles of conditioning regimen in both autologous and allogeneic hematopoietic cell transplantation, types of regimens and different intensities, and finally, I will close it up with graft resources. So to start with, I'll share with you transplant activities and indications in the US provided by the CIBMTR. CIBMTR is, as you all know, is a collaborative working group of more than 450 transplant centers worldwide that contribute to the data on transplant performed at each center and reported to the Medical College of Wisconsin in Milwaukee. So as we see in this slide, for autologous transplants in green, the highest indications is multiple myeloma, followed by non-Hodgkin and Hodgkin lymphoma. For allogeneic transplant, the highest indication is acute myeloid leukemia, followed by MDS MPN, as well as acute lymphocytic lymphoma, leukemia. This slide shows the estimated annual number of transplant recipients in the US by transplant type. Again, in green, you see the autologous transplant that has been steadily rising. The bump in the increase here of autologous transplant in the 1990s is from the time that autologous transplant was performed for both breast cancer patients. But since that has been stopped, the activity dropped significantly in early 2000s. But again, as you see, it's steadily increasing. Maybe it has plateaued in the most recent years. In allogeneic transplant, though, you will see that it has been steadily increasing. Now, this slide shows selected disease trends for autologous in the US. So multiple myeloma is the highest indication for autologous transplant, and has continued to increase. And lymphoma in green we will see that although there has been some increase, but in the recent years, you will see that it has plateaued and maybe it has, dropped a little bit. And why is this? Because there have been a lot of novel agents in the lymphoma land, and with the advent of now CAR T cells and other modalities, the activities in lymphoma has decreased. Okay, now, what is the rationale for conditioning regimen? Why do we give conditioning regimen? So in autologous transplant, we basically, the focus is cytoreduction or cytoreduction, and ideally eradicating the malignancy by higher intensity of the preparative regimen. And the other aspect is that we want to supply sufficient immune suppression by giving this conditioning regimen to overcome the host-mediated rejection of the graft. So these are the two, the main reasons why we use conditioning regimen. Again, in autologous setting, you really are reducing the tumor burden, and you will just give the stem cells as a rescue. So it's really, the rationale is being able to give those higher doses of chemotherapy, versus in allogeneic transplant, you will see varying intensities of chemotherapy with and without radiation, not only to reduce the tumor burden, but as I mentioned, to suppress the host immune system to allow engraftment. Now, the concept of high-dose therapy was developed in the 1950s and 1960s by Skipper and others, and it was based on when they observed this steep dose-response relationship for the anti-cancer drugs. So there was high number of cancer cells that were killed when the doses were increased, and this relationship was exponential. Now, alkylating agents, meaning, Melphalan, busulfan, thiotepa, cyclophosphamide. These are the cornerstone for conditioning in autologous and in allogeneic transplant. Alkylators do not show cross-resistance and have a steep concentration-response relationship. Their activity is dependent on the extent of the DNA damage and repair, so combining them with drugs that inhibit DNA damage and repair results in synergistic effect, and therefore we frequently combine them either with each other or with agents from other classes. Melphalan, a few words on Melphalan. So in high doses, meaning 100 milligram to 200 milligram per meter square, is used as preparative regimen, both in autologous and allogeneic transplants. We use it as monotherapy, only Melphalan, in multiple myeloma patients, and in combination in many of the autologous or allogeneic regimens, and I have put some references. You're all aware of this. The choice of high-dose therapy has traditionally been based on, the institutional experience, the institutional preference, and several regimens are considered standard and routinely used. But the most commonly used high-dose therapy in Hodgkin and non-Hodgkin lymphoma are these three that I have put here. So BEAM, the carmustine, etoposide, cytarabine, Melphalan. And I would love to hear after my talk to see what your standard conditionings are over there, because I'm sure that they, there are so many different regimens, and I would love to know about your practices too there. The other regimen that is commonly used is CBV, cyclophosphamide, carmustine, etoposide, or TBC for CNS lymphoma, which is thiotepa busulfan and cyclophosphamide with very good results. So this is a study by Dr. Chen and colleagues that they conducted a large retrospective registry study to analyze the impact of several commonly used regimens on clinical outcome in lymphoma patients. So the study was conducted between 1995 and, they looked at these patients that were transplanted, that underwent autologous transplant for lymphoma between 1995 and 2008. There were 4,900 patients that were studied, and the regimens that they compared to one another were these that are listed here. So it was BEAM, it was CBV high and low, and the difference between high and low was the dosage of the BCNU, 450 milligram per meter square versus 300 milligram per meter square with BUSI and TBI. And the outcomes that they looked at were overall survival, idiopathic pneumonia syndrome, or IPS, transplant-related mortality, TRM, and relapse or progression and progression-free survival. The results were analyzed by different histologies. So in their study, they noted that IPS, or idiopathic pneumonia syndrome, was most common after CBV high as well as TBI-based regimens. When they compared to BEAM, the hazard ratio for CBV high was 1.88, and for TBI, it was 2.003. So in the left, you see that the 3-year overall survival was superior with BEAM in Hodgkin lymphoma and diffuse large B-cell lymphoma. Transplant-related mortality was anywhere between 4 to 8%, and the CBV high was associated with higher mortality in diffuse large B-cell lymphoma. Now, this slide shows the trends in autologous transplant in US by recipient age. So as you see here, the patients that are above age 60, between 60 and 69 are in green, and 70 and above are in orange. So the autologous activity has been grown and increased, especially in the older group, which is a big achievement. And this achievement, this increase in the number of transplants and the age is basically reflects that nowadays we can take patients to transplant safer. We have a lot more supportive measures to support the patients through transplant, improved access, and better patient, we have a lot of tools to select appropriate patients for transplant and not to eliminate patient or exclude patients just based on their ages. This shows the causes of death of adults after autologous transplant. So autologous transplant is done, it's safe, we do it, but there is a problem, and the problem is that a lot of these patients, and a lot of them, they die from their primary disease that they were transplanted for. And so there is an unmet need, I think, in improving the strategy of autologous transplants so that we see less relapses in these patients. I have written a review article on the strategies to improve the outcomes of autologous transplant. I have listed it over there if you wanted to take a look. I think, I have mentioned everything that has been done so far, and what are we studying these days, how to improve the outcomes. Anyways, this is an area that we need to improve upon. Now, going to a little bit of history on allogeneic stem cell transplant. So as you all know, the first allo transplant was performed by E. Donald Thomas in 1957, and the first long-term engraftment was seen in 1963. At Memorial Sloan Kettering Cancer Center, the first allo transplant was performed in 1973, and the transplant was founded, the field it was founded by doctors Robert Good, Richard O'Reilly, and Dr. DuPont. In 1977, there was the first large trial for transplant, and 1998 was when reduced intensity transplant regimens were came into the picture. So reduced intensity regimen, or forced or RIC. So this this was developed when the immunologic effect of the graft contributing to eradication of disease was noted by the virtue of lower relapse rate in patients with graft versus host disease and in those who had unmodified graft compared to those who had an autologous transplant or a T-cell depleted graft. Now, how do we define the intensity of conditioning regimen? So this is how we base and classify the intensity. Basically, whatever regimen that can give you irreversible pancytopenia, and you would need to have stem cell support for it, is considered a myeloablative regimen. On the other spectrum, on the other end of the spectrum are non-myeloablative regimens. The pancytopenia is minimal, and stem cell support is not required. Anything that doesn't fit myeloablative and non-myeloablative is considered reduced intensity conditioning. So there's a whole lot of regimens in the RIC area. This is showing the conditioning intensity. So again, the low intensity regimens rely on graft versus tumor effect to eradicate the malignancy. And they are obviously associated with decreased regimen-related toxicity. And on the other end of the spectrum, the high intensity regimens, they increase the anti-tumor effect, yes, but at the same time, they have more toxicities. Now, in this slide, I'm showing you the doses of the agents which are considered to be myeloablative. So I know that you don't use total body irradiation, but just briefly, if the TBI is more than 5 gray single fraction, or if it's more than 8 gray fractionated, it's considered myeloablative. Busulfan, if it's more than 7.2 milligram per meter square IV, and I suspect you are using IV as well and not PO, it's considered ablative. If Melphalan at a dose of 150 milligram per meter square and above is ablative. Viatipa at a dose of more than 10 milligram per meter square, milligram per kilogram is myeloablative. Triosulfan, which we don't, it's approved in Europe, it's expected to soon be approved in the US as well. Doses of 30 gram per meter square. If it's higher than 30 gram per meter square, it's considered myeloablative. So know these dosages, and anything below these dosages will be reduced intensity or non-myeloablative. And this now shows, it's classifying what's non-myeloablative, what's reduced intensity, what's myeloablative. So basically, flu TBI 200 is non-myeloablative. In the reduced intensity conditioning regimens, we have Bu2 flu, Bu2 flu, MEL flu, FMT flu, MEL, Thiatipa, flu trio, if it's less than 30 gram per meter square, and the beam, they're considered reduced intensity. Now in the myeloablative setting, you have the BuSci, and I know that now you're mostly using the BuSci regimen. And if you go with the high dose TBI, it's myeloablative. But in the category of myeloablative, you still have, options to reduce the toxicity of those ablative regimens. So by replacing the Psi or the TBI by fludarabine, you're reducing the toxicity. And this is another slide that I liked to share. It's basically, are you giving TBI? Yes, no. You're not using TBI, so we don't need to go that route. But if you're not giving TBI, okay, you're using the alkylating agents. Yes. What are the alkylating agents that you use? And based on the dosages that you use, they will be divided as myeloablative or reduced intensity conditioning regimens. Now, how do we choose conditioning regimens? So what are the criteria we want when we want to, choose a regimen for a patient? So we look at the diagnosis, right? So most of the myeloid malignancies like acute leukemia, MDS MPN, ALL, you prefer to give myeloablative regimens if the patient can tolerate. For lymphomas, you don't need the ablative regimens. We know that lower intensity, reduced intensity, or even non-myeloablative regimens, especially in the indolent lymphomas, have very good results. And we're saving that toxicity. We're saving and sparing the patient from those extra toxicities of myeloablative regimens when we can give reduced intensity or non-myeloablative. So diagnosis is one important thing. Second, we look at the age. So now, as I mentioned, age alone cannot be determining, what intensity you can receive, but it's one criteria that comes into account. So generally speaking, 60 and younger generally can tolerate an ablative regimen if the diagnosis is as such that requires an ablative regimen. 60 and older, depending on how functional they are, what their comorbidities are, you will then, and what's the diagnosis, and all of those, you will decide whether to go with reduced intensity or ablative regimens. Comorbid conditions is very important. We routinely use it to determine, the intensity of the regimen. We follow the hematopoietic cell comorbidity index that was developed at Fred Hodge by Dr. Mohammed Soror. And so those that have low HCT/CI can tolerate a higher intensity dose. Those that have high HCT/CI, we prefer not to give them high intensity regimens. The other factor that determines the conditioning is the remission status. So if the patient is in complete remission, then you can use the reduced intensity even in myeloid leukemias, and not necessarily going up to myeloablative regimens. So again, remission status is important. And finally, stem cell sources, the stem cell bone marrow. Is it peripheral blood stem cells? Is it cord blood? All of those will play into factor when you're determining what, or when you're choosing and selecting the conditioning regimen. So this slide shows the trends in allotransplant in US by recipient's age. So again, as we saw before in the autologous transplant, the patients older than 60, we see in the recent years, there is an increase in the activity of transplant in older patients, even above 70. And this is a big achievement. And this slide shows allotransplant in US by conditioning intensity and by age. So this puts the conditioning into the figure as well. So the standard MAC is in green at the bottom. The RIC in age 50 and younger is in red. And the RIC in 50 and older are in purple. So as you see, there is a lot of RIC used in older patients. A few words on TBI regimen. So total body irradiation is a very effective antineoplastic agent. The dose, the fractionation, the interval between the fractions impact the antineoplastic as well as its toxic effect. Fractionation decreases the organ toxicity while maintaining the antineoplastic effect. And hyperfractionation, multiple fractions daily with lung shielding has shown to have decreased the interstitial pneumonitis from 50% down all the way to 4%. So a lot of things have happened in the TBI and radiation world and has made it really safe for our patients. Now, what are the toxicities of high-dose TBI? So the immediate toxicities, nausea, vomiting, peritonitis, xerostomia, mucositis, diarrhea, interstitial pneumonitis, renal injury, and veno-occlusive disease. Delayed toxicities of TBI, infertility, cataract formation, hyperthyroidism, thyroiditis, secondary malignancies, and growth and developmental delays in children. So, a lot of centers and a lot of countries, such as, in Iran, I hear that you're not using TBI because you can use alkylating agents to replace that TBI with similar effects and efficacy. So one of the most common agents used is busulfan. It was originally available only in the oral form, and it has substantial variability in plasma levels and PK levels, and the low levels were associated with increased graft rejection. The high levels were associated with regimen-related toxicity and veno-occlusive disease. But with targeted dosing, now we don't have any problems with using busulfan, and it's one of the most common agents that is used for conditioning regimen in allogeneic transplants. So this is a registry study, and this study compared high-dose TBI and Cy versus chemotherapy-based, high-dose chemotherapy-based regimen. They looked at leukemia patients because we know that in leukemia, intensity matters. So it was 1,230 patients with AML in first remission that received allogeneic transplant from matched sibling or matched unrelated donor between 2000 and 2006. And if you see here, the non-transplant mortality significantly lower in those who received the BuSci regimen, whether it was IV or oral, they did better in terms of non-relapse mortality. This shows the disease-free survival and overall survival. Again, both of them better in BuSci compared to high-dose Cy, high-dose TBI. So better leukemia-free and overall survival, less NRM, and AML-CR1. So we're good with replacing TBI with Bu. Now it was BuSci myeloablative. Then I brought another registry study. This time they compared, it was basically comparing the BuSci, which is the ablative Bu, and the Bu-Flu, which is the RIC regimens. So the Bu-based regimens with the TBI-based regimens, and again, myeloid malignancies, AML, CML, MDS, 1,400, slightly more than 1,400 patients were in the study. There was no difference in progression-free survival or graft versus host disease. And busulfan-based regimen resulted in superior 2-year overall survival, 58% versus 48% in TBI, with no increased risk of relapse or transplant-related mortality. And this is the figure. It shows the probability of overall survival in Bu versus TBI, which is higher. Now, then what's a reduced toxicity but myeloablative conditioning regimen? So again, to reduce the toxicities of a ablative regimen, now this time Cy was replaced by Flu, okay? So Flu Bu4, Bu 3 or 4, we said that it's TBI, is considered ablative, right? So when you combine fludarabine with this doses of Bu instead of the Cy, this will be reducing the toxicity. Similarly, combination of triosulfan and fludarabine as well. Fludarabine has synergizing effect with alkylators by inhibiting the DNA, and Flu Bu4 had better toxicity profile than targeted BuSci in patients with myeloid leukemias. And one of the studies was from Iran that I cite here. This slide shows the common conditioning regimens in AML or MDS. So if you look at the myeloablative group, so you see the TBI is only 25% of the MAC regimens. Majority of the patients that receive MAC regimens are receiving Bu-based regimens, so about 67%, right? In the RIC world, there is, I would say, about a third of each. So a third using TBI-based regimen, a third of them using Flu-MEL regimen, a third of them using Bu-Flu regimen. So this concludes, okay, and this is a regimen, Flu-MEL, again, a RIC regimen that was basically with Melphalan and fludarabine, and even in the AML and MDS, if the patient is in CR, complete remission, the survival was still good. 66% in one study, 71% in the other. But of course, and those that go into transplant with active disease, they don't do well. So that's why, remission matters when you're choosing the intensity of regimen. Now, shifting from myeloid leukemias and MDS, MPN to now lymphoma land. So in this is a registry study that basically used reduced intensity conditioning in diffuse large B-cell lymphoma. They evaluated all patients that had received allotransplant between 2008 and 2016 and had received a reduced intensity regimen. And those were fludarabine, Bu2, flu MEL, or beam. There were 562 patients in the study. There was no difference in chronic GVHD, progression-free survival, or overall survival between these RIC regimens. Flu-MEL, though, had a lower risk of relapse or progression compared to flu-BU. But flu-BU had the lowest risk of non-relapse mortality. So the conclusion of this study was, you know, if you have a less fit, heavily pretreated patient, then you may choose flu-BU over other regimens because the non-relapse mortality risk is lower. And this is shown in these two figures. So non-relapse mortality was lower in flu-BU, and the relapse rate was lowest in flu-MEL. Now, another registry study, this time RIC, again, RIC and non-Hodgkin lymphoma, evaluating flu-BU2 versus flu-MEL versus flu-Cy versus flu-Cy TBI. It's larger number of patients, so 1823 patients. They received peripheral blood stem cells from an HLA-matched sibling or an unrelated donor, and the graft versus host disease was calcineurin-based regimen. And again, I mean, flu-BU and flu-Cy, with or without TBI, had comparable overall survival. The flu-MEL in the study was associated with higher non-relapse mortality, higher graft versus host disease, lower overall survival. So they suggest, this study suggests that maybe flu-MEL may have a negative association with overall survival and higher non-relapse mortality as seen here. So the flu-MEL is this dark green. The overall survival is lower in their study, and the non-relapse mortality was higher. So again, I mean, if there is any concern with a fit patient, fit or fitness, if they're fit enough or not, maybe a Bu-flu would be preferred to Melphalan. Okay, now going to graft sources, the last part. So what are the graft sources? We have peripheral blood and bone marrow, stem cells from match-related sibling donors. We have peripheral blood or bone marrow from matched unrelated donor from this registry. We have peripheral blood or bone marrow from haploidentical donor. And I should have said that we also have peripheral blood or bone marrow from now mismatched unrelated donor. And finally, we have the cord blood units. So as you all know, the HLA markers are inherited. We get half of our genes from our father, half from our mother. And so the chance that the siblings are matched to one another is only 25%. We match up to 12 HLA loci, but the standard is to match only on 8, which is HLA A, B, C, D, R. Sibling donors for allogeneic transplant, about 70% of patients who need a transplant, unfortunately, do not have a fully matched donor in their family. And they really depend and rely on Be the Match to find a donor and save their lives. Now, Be the Match over the past 30 years has operated by the National Marrow Donor Program and has managed the largest and the most diverse marrow registry in the world. This registry includes 37 or more than 37 million healthy volunteer donors, and they also include more than 500,000 cord blood units. What is the likelihood of finding a match? So given the current makeup of the registry, the likelihood of finding a match is very different depending on your your ethnic and racial background. It's anywhere as low as 23% to anywhere as high as 77%. And because these genetic traits are inherited, patients are most likely to match donors who share the same racial and ethnic background. So improving the ethnic diversity of the registry improve the odds of finding a matched donor, regardless of their ethnic background. So, and this shows the diversity of adult donors in the Be the Match registry in 2017. So 45% of the representation was from white donors. 19% was from those that had, diverse racial and ethnic background. And then 36% of the donors did not answer. We don't know what their background was. So now at MSK, Dr. Barker, our cord blood specialist, she did a study. She looked at basically within a period of time, we looked at all the patients that received allogeneic transplant from a perfectly matched unrelated donor. Who were they? What were their donors? And then in the same period, those that received cord blood transplant, who were the donors for them. So if you see here in blue, in different shades of blue, this is all the donors or all the patients that have a non-European background. So more than 3/4 of the patients that received a fully matched donor had a had a European background. I mean, white, okay? So in other words, more than 3/4 of the patients that have a European background will find a perfect match in the donor registry. Now, on the other hand, if you come to this pie, you will see all the ethnic and racial minorities. These, more than half of the patients that received cord blood transplant are these ethnic and racial minorities, which includes the Middle Easterns. So again, I think, we have less representation of volunteer donors in the registry. And what I want to urge you in Iran is to ask our Iranian population, young adults, to volunteer to be a healthy donor and to be represented so that we can increase this pool in the unrelated donor registry, because this is a problem for us as Middle Easterns. We don't get, whenever we need a transplant, we are relying on alternative donors mostly. So this is a problem, and I want to urge you to, encourage the people to volunteer more. And this is how we triage donor selection. So we have a patient here in need of a transplant. If they have a suitable, sibling donor, perfect, we're done. We'll go with, perfectly matched sibling donor, Okay, now, there are cases that there are no suitable matched sibling. Then what? Then we will look at the registry. If there is a high likelihood of having a perfectly matched, which is 8 of 8, of unrelated donor, then we will activate the unrelated donor, especially if, the transplant is not urgently needed. And we will ultimately go with the 8 of 8 unrelated donor. But in cases, but that, as you all know, may take up to 8 weeks for the donor to be, selected, cleared, availability. So it may take up some time for the donor to be available. In those cases that the transplant is urgent, in those cases, we use cord blood transplant in them, and which we can procure the units in about 2 weeks. Now, let's talk about the patients that do not have a fully matched unrelated donor in the registry. So their search is basically either fair or poor. Those are the groups that we go to the alternative donors. And what are the alternative donors? So it's cord blood, haplo, and mismatched unrelated donor. Now, again, if there might be some availability issues with the unrelated mismatched donor or the haplo, relative donor, and in those cases, we will shift to cord blood. Again, if urgency is, so urgency also trumps the cord blood. So this is how we do it at Memorial Sloan Kettering. Okay, now this slide shows the allogeneic transplant recipients in the US by donor type. Okay, so in orange are, recipients of donors that were unrelated, both bone marrow and PBSC. And this is the highest number of patients. So most patients get an unrelated donor, okay? The matched sibling donor, as mentioned, is about 25% of the cases, and it's steady. It's not going to get any better. The other relative, meaning the haplo, in recent years, especially like, in 2013 and onwards, we see an increase in haplo usage, and it has actually reached the number of transplants that are done with a matched related donor. And then finally, in light blue is the cord blood donors that is steadily decreasing, especially with the advent of post-transplant SLI and haplo. So now, haplo-identical transplant in the US by conditioning intensity. MAC is in blue, RIC is in green. Okay, so as we see in the recent years, the trend is that we're using more RIC than MAC for haplo transplants. Again, it really depends on many other aspects of as well. It's not only the graft source, but a lot of other factors will play a role in it. Now, I brought a few studies on haplo because nowadays, many centers, many countries are using haplo more and more. So I brought a few studies that I found helpful and good. So one is haplo transplant. They compared the haplo transplant versus a matched RIC transplant in lymphoma. So it was performed in 900, almost 1,000 patients. Most of them had matched sibling donor. The TBI, the GVHD prophylaxis for them were CNA, calcineurin inhibitor based, and 180 of patients had haplo transplant with post-transplant SLI. So the platelet recovery was delayed with haplo. The chronic GVHD at 1 year was significantly lower in Haplo than in perfectly matched sibling. So, I mean, there was no difference in non-relapse mortality, relapse, progression-free survival, or overall survival. And the chronic GVHD was lower in transplant. So actually, this is why Dr. Kumarsi, you mentioned that now you're even like sometimes preferring to go with a haplo, or your preference is haplo transplant. It's across the world, so it's very similar to a matched sibling transplant, with the difference that the chronic GVHD is much lower with the PTC. This slide shows the transplant recipient donor type, again, so focusing on donor in the US by age group, okay? So in orange, these are the patients that received unrelated donor bone marrow or PBSC. We see that in all age groups, in pediatrics as well as in adults, most of the donors were unrelated, bone marrow or PBSC. And this was followed by, it was followed by these groups, right? Which is the match-related donor. In all different categories. Now, in the adults, the third in line was Haplo, 19, 15, 16%, versus in pediatrics, chords were done more than Haplos. And then as we see, like chords is, as with the increasing age, chords are not really being used in older ages, including at our center. So this shows the batch-related donor allotransplant in US in patients, in adult patients. Blue is bone marrow, green is peripheral blood, and you will see that most of the activities is with peripheral blood. And haploidentical transplant in US by graft type, in Haplo world too. So mostly nowadays it's PBSC rather than the bone marrow. So this is another study, a registry study. Now this time we are comparing peripheral blood versus bone marrow for haplo-related donors and PTC. So it was performed in 681 patients with hematologic malignancies, leukemias and lymphomas between 2009 and 2014. The endpoints were transplant outcomes by graft type. Most patients received bone marrow. Most patients that underwent bone marrow transplant, they had received a Cy/Flu TBI conditioning regimen, so really a non-myeloablative regimen. In the PBSC recipients, 46% had received RIC versus MAC. So as we see here, the grade 2 to 4, grade 3 to 4, as well as chronic GVHD was lower with the bone marrow than with the PBSC. The overall survival didn't matter, it was similar. Non-relapse mortality was similar. The relapse rate was higher in the bone marrow compared to PBSC. So the count recovery was similar. The risk of GVHD, both acute and chronic, were lower in bone marrow. And there were higher relapse risks with bone marrow, but that was limited to the leukemia patient when they analyzed that group further. It wasn't increased in the lymphoma patients. And then now, leaving the Haplo world, coming to mismatched unrelated. bone marrow. This is just using bone marrow with PTCy. It's an NMDP sponsored study. It was a prospective study. It was phase 2. They studied 80 patients with leukemia and lymphoma between 2016 and 2019, and they were HLA matched at 47 of 8. The primary endpoint was overall survival to be more than 65%, and other secondary endpoints that are listed here: engraftment, GVHD. And so in this study, there were 40 patients were in the RIC group, 40 in the MAC group. The RIC, all of them received Cy/Flu TBI 200. In the MAC, there were different regimens that were allowed, so Bu-Cy, Bu-Flu, and Cy/TBI. And then they compared their results to the real world results from the CIBMTR. Now, interestingly, as we expect, 48%, almost half of the patients were from racial and ethnic minority backgrounds. So in this figure, you see that, the risk of relapse, both in MAC and in RIC, is similar. The non-relapse mortality, okay, both in MAC and RIC here is similar. The risk of acute GVHD and chronic GVHD is lower with reduced intensity. So reduced intensity is red, and MAC regimens in blue. So GVHD was lower. And overall survival was comparable. So the conclusion of the study was that even we can use mismatched unrelated donor if we use PTCy, and it's not only feasible, but it's effective. The results were good. And the last study that I bring here to show, again, in the unrelated, mismatched unrelated setting, okay, using this time PBSC. So Dr. Shaw's study was using bone marrow. This is using PBSC and post-transplant Cy. This is a pilot study. The number of patients are low. It's only 38. 19 patients received RIC conditioning with flu MEL, and 19, so half of them received this TBI-based regimen, right? And then they got the post-transplant Cy, and they got the TACRO and MMF, and these are the results of their study. So the 1-year survival was 87%. This is in red, okay? The 1-year graft-free, relapse-free survival was 68%. This is again in green. So the relapse rate was about 11% for all, and the cumulative incidence of non-relapse mortality in yellow at day 100 and 1 year was really 0 and was 11%. So very good results. Again, it's a very small pilot study, but I brought all of these studies just to show you that, you know, these days, everyone should have a donor. So no one is left without a donor, which is a great, great improvement and achievement for the field of transplantation. And I'm closing my talk with showing you this last slide. It shows the trends in allogeneic transplant in the US by recipient age. So as we see here, so in blue are those that are older than 65. And as you see, there are, since 2000, there have been increasing number of patients that are older than 65 and are being transplanted, being recipients of allogeneic transplant. And, in 2019, 26% of the patients were older than 65. And the increase of transplant age reflects, again, better patient collection, improved access, improved safety, and better acceptance by the third-party payers because of its success. And with that, I thank you all for your attention, for your time. This is my email address. Please feel free to email me with any questions or any comments. My office number and my Twitter address is listed there for you to use. And I'm happy to take any questions. Was everything very clear?
Yeah, I don't know if Dr. Q-Mercy is on to moderate the question.
Yes, thank you so much. It was an awesome presentation, Dr. Dahi. It was really a very updated information and very delightful for us because you bolded the non-TBI regimens and their good results very much. I really enjoyed it. Thank you so much.
Of course, my pleasure. I'm glad that you found it helpful.
Yes, it was really helpful. I would like to ask the questions if you let me.
Of course, please go ahead.
Okay, one of our very dear fellows is asking that what conditioning regimen do you suggest for ALL patients who have undergone heavy treatment before reaching the time for HSCT if they are having haploidentical donors?
So again, a lot of factors, as I mentioned. So ALL, we generally prefer ablative regimens. But if someone is, previously heavily pretreated, if they're older, if we think that based on their, prior treatments, based on their comorbidities, they cannot tolerate a myeloablative regimen, we can consider reduced intensity regimens in those cases as long as the patient is in CR. And then, you're basically using chemo-based regimens. So Bucy may be too much for this special case. Maybe you will go with a Bu-Flu regimen or Bu-Flu regimen. It's still myeloablative, but reduced toxicity. And yet, if you think that they cannot tolerate an ablative, even if it's reduced intensity, then you will even consider RIC in them, especially if they're in CR. So Melphalan, Bu-Flu 2, or other RIC regimens.
Thank you. One of our good colleagues, Dr. Ashrafi, is asking for ALL patients if they have had extramedullary involvement, especially CNS involvement, what radiation-free regimen do you recommend?
Yes, so we generally prefer to go with high-dose TBI, but even with the high-dose TBI that we give, we also, like if it was like we do give boosts radiations to the CNS or the testicles or wherever need be. So generally speaking, high-dose TBI with radiation boosts.
Mm-hmm. We send our patients to get CSI before giving them conditioning regimen. This is how we manage not having TBI, actually, you know. I myself had a question, Professor Dahi. What do you recommend about the timing of administration of ATG? Do you suggest that maybe administering ATG in a bit more duration before transplantation would be a better option?
That is something that we are currently studying. So we used to give ATG on day minus three and day minus 2, but now we're shifting it to, earlier in the conditioning. And it's based on the studies that Europeans have done. And nowadays we're even like doing based on exposures. So when the ATG is given earlier, the results and the outcomes have been better.
And between ATG and post-SI, do you recommend when we administer post-SI omitting the ATG, or you think in haploidenticals and maybe mismatched unrelated, it's better to administer both of them?
So we generally use the PTC, and we do not use the ATG for the PTC. When we're giving the PTC. So, when we're giving post-transplant cyclophosphamide, you don't necessarily need ATG. In what context do you use both?
One of our dear attendings from Talaqani Hospital, Dr. Parkhide, is asking what is the recommended regimen for aplastic anemia patients, especially in their second transplantation. I would like to know a good regimen for them if we have a haploidentical donor.
So my specialty, so I have not personally dealt with aplastic anemia patients much, so I can share with you by email what we have done, especially in the pediatric setting. We have done it in allotransplant, but I don't deal with aplastic anemia. But in general, yeah, so I can share that. I'm sorry, did your question was what conditioning for aplastic anemia?
Yes, most of the recommended conditionings for aplastic anemias who are having haploidentical donors contain TBI. I would like to know what other options may be possible. If you
I can share with you what we have done here, but later on, because I have to look it up, I'll be happy to do that. I do not believe that we have done any haplos for aplastic anemia, but I'll check.
Thank you.
Sure.
What supportive care do you use during your conditioning, maybe for lowering the adverse effect of, for example, cyclophosphamide on heart and the kidney and all that? For example, do you use NAC or UDCA for lessening the incidence of SOS and all that?
So with high-dose cyclophosphamide, we give Mesna with high-dose cyclophosphamide, and with or without fluids to reduce the incidence of hemorrhagic cystitis. That's what we use, Mesna.
You don't use NAC for lowering the cardiac adverse effect?
I'm sorry, what is NAC?
N-acetylcysteine. Don't you use it?
No.
No, you don't.
No.
Okay, and dear audience, no other question? Do you think that JAK inhibitors would be a good option for GVHD prophylaxis in the future? Do you use them?
Maybe. I think, I mean, it really has revolutionized, I think, the graft versus host disease treatment. I mean, you know, even with the perfectly matched sibling or unrelated donor, you will see a lot of graft versus host disease still. And and especially after cord blood transplants, so we do a lot of cords and we see a lot of GVHD for treatment. We have been very successful with JAK inhibitors, and I think it has really changed the field. And so, yes, maybe sometime, you know, in the future, yes, it's potentially foreseeable that it can move up to earlier.
Mm-hmm. In second HSCTs, what do you recommend in patients who have experienced secondary graft failure? Yeah. What regimens do you recommend for the second HSCT?
Yeah, so this is a very good question, and it's really, we don't have a uniform approach to what regimen we use for secondary, you know, transplant, for a second transplant, because, you know, again, all those factors, diagnosis, age, comorbidities, prior, you know, treatment history, graft source, all of those play role. Now, what we are discussing is that when treosulfan gets approved, or even now that it's not approved, but we can use it as in the setting of clinical trial, we may be using, you know, treosulfan, fludarabine, and TBI-200, which is still myeloablative, but reduced toxicity for a second transplant, acute leukemia or MDS.
Yes, okay. One of my good friends, Dr. Rostami, is raising her hand to ask a question. Dr. Shadaman, would you please unmute her?
Oh, I can't. I mean, it's not. I think the host of the meeting should do it. I don't have that.
Meanwhile, you could ask your own question.
Yeah, no, thank you. So thank you very much for this great talk. I was wondering if you could comment on what do you use at the memorial for reduced intensity transplants for non-Hodgkin lymphomas or CLL? What's your standard practice?
So again, there is no standard practice, but we, you know, based on all of those things that I said, it will be chosen. And CLL nowadays, we rarely take them to transplant, but we have done, you know, when they have that Richter transformation, we have taken them to transplant, and with very good results. So depending on your graft, right? If you have a haplo-identical graft and the patient is in remission, then you can use non-myeloablative regimens, so Cy/Flu, TBI-200. If you need more intensity, you will go to Bu-Flu, or you know, Flu-Mel, and with very good results, actually. Although I should say that we're, you know, we don't see that many CLLs coming to transplant any longer.
Yeah, correct. I mean, in the settings where there's not much access to the new drugs, transplant remains a major option for high-risk patients. That's why I asked. Yeah, I wasn't sure what's the practice is in Iran for example, CLL, or I don't know what reduced intensity conditioning is being used.
Right. We neither see many CLL patients in transplant settings, actually. Yes, most of them use medical, other kind of drugs, and they don't come to transplant very often, actually. And Dr. Rostami has asked, what is your recommendation for donors retransplant after graft failure? If the first donor, you choose the first donor again, or you choose another donor in the second transplant?
So If you have the donor available, the first donor, yes, give them, use the same donor. If you don't have the same donor, meaning you went with a cord blood transplant and the cords are done, you have given it and you have graft failure, then you use another donor.
So even if you have a low chimerism, under 5% maybe, you still prefer to choose the same donor in the second transplant?
Again, this is so rare, right, that there is not one practice. So the rate of graft failures is very low these days. And again, if you have the same donor, we generally have used the same donor as for the second transplant or as a boost. And if we don't have the same donor, then we give another donor source.
Yes, I got it. Okay, thank you so much, Professor Dahi. We really enjoyed your talks and you learned a lot. We hope to see you soon in Iran, so we could be a better host for you here. Thank you so much.
Yes, and I want to thank you all very much, each and every one of you, for your time and for inviting me. And I would love to come to Iran and, hopefully after this Corona pandemic is over, that is a place that I would love to go back and meet you all in person. And in the meantime, we can stay in touch, virtually.
That's awesome. Thank you so much. Bye-bye.
Thank you very much. Have a good day. Thank you.
Bye-bye.
Bye-bye.